Welcome. I am Terry Tropin, and today I'll be discussing the new evaluation and management codes for audio, video, and audio-only services. First, let me give you some information about myself. I have a master's in healthcare administration informatics from University of Maryland Global Campus, and I have an RHIA and CCSP certifications. Also, I'm an AHEMA approved ICD-10 CMPCS trainer. I taught at Montgomery College in Silver Spring for over 20 years. I've also written some books. These are based on the study guides that I wrote for my classes because I thought the textbooks were confusing. I wrote a book on evaluation and management coding, on ICD-10 coding, on PCS coding, and every year I come out with a book that gives you the changes for the CM and the PCS books for that year. All of these books have been updated for 2025 and are available on Amazon. Okay, here is what I'm going to talk about today. What are these audio, video, and audio-only telemedicine codes? Why were these codes added? Who can report these codes? What are the general guidelines for these codes? And more specifically, how do you select audio-video codes and how do you select audio-only codes? First, what are these codes? CPT 2025 will include new codes for synchronous audio-only and audio-video telemedicine visits. These visits take place between a patient and a physician or other qualified healthcare professional, QHP. These are non-face-to-face services which include a back and forth communication, like a conversation. So they're talking to each other directly, not like an email or a text message, but directly back and forth with each other. So what are the actual codes? Well, we have these codes here for audio-video visits, and you have separate codes for new patients and established patients. New patients are 98000 to 98003. Established patients are 98004, 98007. These codes are audio only, listening only. 98008, 98015, you have codes for new patients and established patients. And finally, you have 98016 for brief synchronous communication, such as a virtual check-in. And these are for established patients only. So these and these can be new patients or established. This one is established only. So you have, why do we make these codes? Well, they replace 99441, 99443 telephone communications by physicians. So most importantly, 98000, 98016, Medicare reimbursement. That's the most important issue, right? Medicare will not reimburse for these services for 2025 except for 98016. Now this may change, but at this point, Medicare will not pay for them. Now, Medicare will reimburse for other E&M services codes reported with Modifier 93, which is audio-only services, or Modifier 95, audio-visual services. Now, you've already been using these perhaps, but those are in appendices P and T in your CPT book. These appendices include a list of codes that can be reported using these modifiers. Now, what about other payers? We don't know. It's unclear at this time whether they will accept them or they will still want you to use modifiers 93 and 95. But we still need to be familiar with these new codes in case they're accepted or if they're accepted in the future. Okay, so the codes 98000 and 98016 are out of numerical order. So you wonder why they keep having codes with numbers if they're not going to put them in numerical order. But that's the way CPT is, unfortunately. So these codes are in the evaluation and management section of the CPT book, but they're after the office or other outpatient services codes 99202, 99215. So they're out of numerical order. So why did they make these codes? Well, according to the National Library of Medicine, telemedicine services first expanded during the COVID-19 pandemic and continue to grow and be accepted by providers and patients. So people have become more familiar with providing services or receiving services using telemedicine. As a reaction to this expansion, these codes were created. Now, telemedicine services are used instead of an inpatient services when medically appropriate to address the care of the patient and when the patient and our family caregiver agrees. Everybody has to agree that this is a good idea. Who can report these codes? Well, I said before, physicians, qualified healthcare provider. These codes cannot be reported by a non-physician provider who cannot report an E&M code, such as a speech therapist. There are codes for speech therapists to do telephone services, and these are 98966, 98968. Remember that synchronous services must meet the same requirements as a face-to-face encounter. The benefits of performing the service using telemedicine must be documented. Maybe either the patient or the physician are a long distance from where they usually are, or maybe the patient is rural. Maybe the patient is bedridden and can't get to the physician's office. There's got to be a reason why the service must be done by telemedicine. Why is it beneficial to do it this way? Okay, so let's look at guidelines. First are guidelines for using these codes for follow-up visits. So for example, visit 1 may be face-to-face or via telemedicine, and now they're having a follow-up visit using telemedicine, using audio only or audio video. For example, a patient may require reassessment due to an unexpected response or complication related to the treatment plan developed during a previous face-to-face or telemedicine service. So during visit 1, a treatment plan was developed, and now there's a problem, and so they do a telemedicine service to reassess the response to the treatment plan. So coding depends on the circumstances. So if the original service, visit 1 and visit 2, are on different dates, report both services. Now, there's no specific time interval between the original visit and the telemedicine visit, only that it's a different date. The follow-up visit may be initiated by the physician, other QHP, the patient, or family caregiver. Okay. Now, if the original visit, visit 1, and the subsequent visit, visit 2, are on the same date, don't report the audio only or audio video code. Report only a code for the follow-up visit. Timing is everything. Okay, also very important, when can you not report these codes? The audio only and audio video codes. You can't report these for routine telecommunications related to a previous encounter. So the provider calls up the patient and says, here are your lab results. No, that doesn't count. You also cannot use these codes if the services are asynchronous, meaning a communication that does not take place at the same time. This is like an email, other online communication, a text. So it's not a conversation. It's one person, and then it can be 5 minutes, 10 minutes, 3 hours before the response, before it's read or there's a response. If it's digital, use the digital evaluation and management service instead of these synchronous codes. You can't use these codes for services for patient oversight by clinical staff, and you can't use these codes if the services lasted less than 5 minutes. Okay, when can these codes not be used? The guidelines have a specific code, guideline for audio-only codes. Audio-only codes cannot be reported for online digital communications except when the synchronous telecommunication technology was developed for the deaf. So this is a conversation at the same time, but it's digital, it's written, it's typing, because the patient, either the patient or maybe even the provider are deaf, and so they need to communicate through digital means. So in that case, you can use this as audio only. Okay, selecting a code. Audio video codes are selected using either time or medical decision making. Audio only codes are selected by time or medical decision making and require more than 10 minutes medical discussion. Okay. When reporting codes using time, we're not going to include time spent establishing the connection, arranging the appointment if the time is less than 5 minutes, and again, time counted for chronic care management or for principal care management services. So prolonged services. Now, sometimes the audio only codes will be longer than the time listed in the codes. Each code is defined by a specific number of minutes spent with the patient and a level of medical decision making. Sometimes the time spent will exceed the time listed in the codes. And we're going to talk about specific times in a minute. In these cases, you may be able to use prolonged services code 99417. You can use the prolonged services code only if the code is being selected using time, not medical decision making, and you use the code for the highest level code in the category, and the service lasted 15 minutes or more beyond the time listed in the code. So if you look at the codes in your CPT book, you'll see that for audio video codes, the highest level for new patient is 98003. The highest level for an established patient is 98007. If you look at the highest level in the audio only, the 98012 is the highest code for the new patient. 98015 is the highest time for established patient. So here's a practice. So audio video encounter between Dr. Smith and his new patient. The encounter lasted 15 minutes. So this is audio video, new patient. And I'll pause for a minute if you want to go to your book and look at this. Okay, so the highest level for audio video new patient is 98003. And that is 60 minutes. So you have 98003 for 60 minutes and then 99417 for the additional 15 minutes. So let's look at more detail with the audio video codes. There are separate codes for new patients and established patients. Now, all of these codes include medically appropriate history in our examination, but these are not defined. This is at the provider's discretion. So for new patient codes, you have 98000 to 98003, straightforward 15 minutes, low 30 minutes, moderate 45 minutes, high 60 minutes. The minutes must be met or exceeded. So these are the baseline, the minimum that you need. So if it's 15 minutes, anywhere between 15 minutes and 29, you're going to do 98000. Once it hits 30, you can move up to 98001. So it's minutes or medical decision making. For established patients, you have 98004 through 98007. Straightforward, 10 minutes. Low, 20 minutes. Moderate, 30 minutes. High, 40 minutes. For the audio only codes, you have 98008, 98015. This is also medical decision making or total time, but there also is a requirement to have more than 10 minutes of medical discussion. If you don't have 10 minutes of medical discussion, you can't use the audio only codes. And these also include medically appropriate history in our exam, just like the previous ones. So separate codes for new patients and established patients. 98008 to 98011, straightforward, 15, low, 30, moderate, 45, high, 60. Established patients, 98012, 98015, straightforward, 10, low, 20, moderate, 30, high, 40. Okay, so audio only, as I said, are by medical decision making and time, but also require that 10 minutes, more than 10 minutes of medical discussion. So what is medical discussion? What's the kind of thing of you know what it is, even though it's not defined. CPT does say, well, this is not part of medical discussion. Establishing the connection with the patient and the provider. Arranging the appointment. Well, yeah, that's not a medical discussion. That's kind of the technical stuff that goes into this. So, but you have to have that 10 minutes of medical discussion. So here's another practice. Provider had telephone encounter with an established patient. Telephone, established patient. When you go through your examples in your textbook, it's a good idea to underline the important sections. I do it automatically now. So telephone, established patients, 12 minutes, medical discussion, total 20 minutes, straightforward. Those are the important words to figure out the level, the code to use. So I'll hold on for a minute while you take a look at that. Okay, so it met the requirement of the 10 minutes. So if you're going by time only, it would be 98013. If you're going by the medical decision making, it'd be 98012. So obviously we're going to do this one. Okay, so technology is great, except when it isn't. There are guidelines for this problem. If during the encounter, audio-video connections are lost and only audio communication is restored. So you had audio-video, you lost the video, and now you only have audio. You're going to report the service that made up the majority of the service. Was most of the service audio only, or was most of the service audio-video? Whichever one was the most, that's the one you use. If you're reporting audio only, the documentation must meet the requirements for audio-only services. That means including that 10 minutes of medical discussion. Okay, so here is another practice. Patient had audio-video encounter with her established patient. So, audio-video, established patient. Encounter included 12 minutes of medical discussion, total of 12 minutes, straightforward. However, 5 minutes into the encounter, video connection was lost. Final 15 minutes was audio only. It happens. So let me pause for a sec. Okay, so the majority of this encounter was audio only. So the code selected will be from the audio only codes. The encounter included the required 10 minutes, so we know it's 10 minutes. So we're going to use 98013 for the 20 minutes. But we can't, the whole audio video part, the 5 minutes audio video, doesn't matter. We can't use the audio video part at all. Okay, and finally, we get to the virtual check-in code, 98016. This is the final new code, and this code replaces HCPCS code G2012, Brief Communication Technology-Based Service. Now, Medicare will reimburse for this code. It won't reimburse for the other codes we've talked about today, but it will reimburse for this code. So this code is used for brief technology-based communication between the provider and an established patient, is initiated by the patient, may or may not be audio only. It's designed to determine whether a more extensive visit, such as an office or other outpatient E&M service, is needed. This service also includes a medical discussion. but the minimum time for this one is only 5 to 10 minutes. The one for the audio only, you'll remember, was 10 minutes. So it's a little bit different. A lot of overlap, but it's a little bit different. So there's also specific guidelines for this virtual check-in code, 98016, for things that happen before, the same day, and things after, okay? So do not report 98016 if the patient was seen within 7 days before the visit. If the provider schedules a future visit 24 hours or soonest available visit after the encounter. Or if the provider sees the patient on the same day as another E&M service. What you're going to do in this case is you're going to take the 5 to 10 minutes from the 98016 and add it to the time of the other E&M service to get the total time for the other E&M service. So it's counted, but it's lumped in with the other E&M service. Okay, so specific guidelines for before, after, same date. So here's a final practice. This established patient called Dr. Jones to discuss his visit 10 days ago. The pain he had been experienced was worsening. Dr. Jones made an appointment for a face-to-face visit on the following day. So let's take a breath here. You can think about this one. Okay. Since the patient was scheduled for a visit within 24 hours, no code is reported. So it's a different day, but it's 24 hours. So it's the following day. So you're not going to report the virtual check-in code at all. Okay, so these codes can be confusing. So here is a comparison. You have audio-video visits, medical discussion, not required. Patient can be new or established. Visit initiated by physician, QHP, or patient. Don't report audiovisual codes on the same day as other in-person E&M code. 98008, 98015, audio only. Medical discussion required, yes, 10 minutes. New or established patient, physician or patient, don't report on same day as another inpatient E&M code. Then you get to the brief communication code. Medical discussion required, yes, but it's only 5 to 10 minutes. Established patient only, visit initiated by patient. And then you have that before, after, same day. Now you can look at table 2, entitled Telemedicine and Non-Face-to-Face Services in your CPT book for a more extensive table on this information, comparing telemedicine and other non-face-to-face services. Now these are great, but as I said, sometimes you can't use these codes. Either the payer won't pay for them or because of the guidelines. It's important to check with your payers to see whether they'll be reimbursed, or to see if they want you to continue to use modifiers 93 and 95 instead. Now, the intent of creating these codes may have been to clarify coding for these types of services, but it's probably just made it more complicated. So modifier 93 is one option. This is added to codes to indicate it's audio only. Modifier 95, audio and video. So you have these possibilities of modifiers. So modifier 95, you can go to Appendix P in your CPT book, and this is audio only, modifier 95. And these are all the services that can be used with modifier 95. Lots and lots of services. I won't read all of them. They're listed right there, but a lot of different codes that can be used with modifier 95. Modifier 93 the codes that you can use these with are listed in Appendix T, audio only, and here are the codes that can be listed with those. Now, some codes can use either modifier 93 or modifier 95. Modifier 93, audio only, modifier 95 audio video, and some you can do either audio only or audio video. Some can use either. Most codes in the psychiatry section. Medical genetics and genetic counseling code. 2 codes in the central nervous system assessment and test section. All medical nutrition therapy codes. All codes in physical medicine and rehab section. And all codes in the education and training for patient self-management section. So there we go. That's all the codes, all the slides for this video. So if you would like a copy of the slides for this video, send me an email, and there's my address, and I will send you a PDF of the slides. Take a look. Here are my books. They are on Amazon. All of these have been updated for 2025, so we are good to go for the upcoming year. If you have questions or comments, also send me an email. Here is my Facebook page. I have lots of other videos if you want to kind of look through what else is there. Be more than happy to have you do that. And thank you very much for listening. I hope you found this helpful. Thank you.